So just let me verify that everything is all right.
Yes.
All right. Well, thank you so much for participating in this activity. We would like to talk a little bit this afternoon about A1C targets for glycemic controls. There were some publications that I shared with the group probably about a month ago about some statements from different organizations about what the A1C should be in patients with diabetes. This is very important in health centers, specifically because 9.2% of patients served in 2016 were diabetic patients, according to HRSA UDS data. That is about, that is similar to the national data. The latest report from CDC is that the 9.4% of those living in the United States have diabetes. However, when we are talking about diabetes that is not well controlled, specifically the measure, the A1C, greater than 9, that is being reported by health centers, that 32% of the diabetic patients in primary care, specifically those served by health centers, have diabetes that is not well controlled, or the levels are either equal or greater than 9. So the document that I was mentioning is from the American College of Physicians, and they had specifically different statements from different organizations about what should be the ideal goal for glycemic control in patients with type 2 diabetes. And I am part of the the primary care advisor group. This is I've been in contact with the American Diabetes Association, and they were a little bit concerned because the different statements could create some kind of confusion. And they basically had a press release saying that the American Diabetes Association recommendation is for patient with diabetes is that the AC should be less than 7, provided the fact that the patient doesn't have any other condition or any other comorbidities, or if the patient was not at risk of developing hypoglycemia. And they mentioned some of the different trials that they used to make that recommendation. So that is in general the discussion that we had with the American Diabetes Association. And before we talk about the barriers to successfully manage diabetes type 2, I would like to ask the group, what are the glycemic targets or protocols or algorithms that you currently use? So, Dr. Magdi, do you have any comments on this?
Yeah, so for our population health measure that we're using a software program called Relevant to be able to look at provider level data and then drill down on specific patients. And then also looks at either by specialty or site or across El Rio. We're using the A1C less than 9 as our quality management tool. But on an individual basis, we recommend strategy depending on the patient's age and comorbidity. So generally less than 7 is the overall target, but as people age, relaxing that as long as it's less than 9, especially for the people over age 80. And then also depending on their comorbidities, if they have, cancer, other problems.
Do you use the same approach with newly diagnosed patients? Is that the approach, or this is just for patients who are known diabetic patients?
So for newly diagnosed, we would generally go by the same approach. So if they are younger and don't have comorbidities yet, definitely being more aggressive, and then loosening the degree of control as they get older and develop more comorbidities.
Okay.
Yeah, if that's what you mean. And I think across the board, there is a lot of provider variation, but I think we're definitely being more aggressive with pre-diabetes and really trying to detect and treat that more aggressively up front.
Now, the protocol basically says that if the patient has any other comorbidity, then you have to be a little bit more careful with when you approach the A1C target. Specifically, if the patient has cardiovascular diseases or if the patient is prone to developing hypoglycemia. But I believe that the less than 9 is a safe approach across the board. Right. Now, in regards to patients who are over the age of 65 or probably older than that, do you still use the same approach?
Of less than 9, yes.
Okay. All right. Silke, what about Med Centro? What is the protocol?
Our protocol say have to be less than 7 if the person is 75 and younger. If more than 75, we ask for less than 8% of the glycemic target.
Okay. And I'm not sure.
For HESA, we measure the uncontrolled patient, more than 9%. That's the one we report to HESA now.
Okay, and I'm not sure if our friend from Tri-City was able to join us. Probably not. Okay. The other, well, as you know, the two primary techniques are the A1C and this patient self-monitoring of blood glucose. Do you use the patient self-monitoring of blood glucose in your patients? Basically, do patients have access to glucometers and so they can self-monitor the blood?
We even give it to them and show them how to use it. We have a card that we developed that they have to write down all the glycemic by day, and they give it to the physician every time they come to visit, and the data is get inside in the EHR.
Do you use the same approach for all diabetic patients?
No, we do that with the uncontrolled patient. We move it to the diabetic collaborative that we have here, and that's the way they start taking care of them.
Okay. What about at the Rio, Dr. Magby? Do you use the primary technique?
The same thing. Everyone has the glucometers, and we have easy access to that through our 430B drug pricing, even for the uninsured. And the degree of how much we push patients to do it really depends on their control. So similar thing. If they're controlled, we don't necessarily push them to do it as much, but if they're uncontrolled, then that's the group we want testing. We did one thing that a big change we made, I think close to a year ago now, is we used to routinely test everyone's blood sugar when they came to clinic. We just do a glucometer check. And we stopped doing that really based on data of some national level studies of some other big systems that did that showed no change in glycemic control, but tremendous cost savings. And so we analyzed that for our own site, and decided that it would be beneficial to do that. And so things have been going very well. I know somebody is tracking our data, and I haven't heard a recent report, but I know that at least the initial data showed no adverse effects from that change, but definitely a cost savings.
Okay, interesting. And is there any problem? Have you seen problem with the use of the glucometer in your patients, and who provides the education? You know, when a patient is going to start using a glucometer.
So this is Joy. So it depends. Sometimes it's our clinical pharmacy team, which may include the pharmacist, but more often the specially trained MA who's on their team. It also might be MAs in the general suite. Could be somebody at the pharmacy itself. We also have several kind of education programs like our diabetes empowerment program, and sometimes it might be through those programs. So there's a variety of different ways.
Okay. What about Med Central, Sylvia?
Yes, we have a health education program here, and all diabetic patients are referred to her to teach her how to use it. Even the physician, the first time the patient have to use the dextro, he's the one who teaches them how to use it.
Okay.
In the pharmacy, we have an office there. The patient can ask to the pharmacist for the education, and she has a private place to can do it with them. It's depending on the patient if they want it or not. But at first, the first one who gives them the education to use the dextro is the physician.
Okay. Now I would like to briefly review the A1C testing recommendations. The American Diabetes Association recommends performing the AC1 test at least 2 times a year in patients who are meeting treatment goals. However, in patients who are not meeting the glycemic goals, the recommendation is to test the patients quarterly. Is that the approach at the Rio, Joy?
Yeah, that is our approach. Maybe with the caveat that we strongly believe in doing things while the patient's present, because we know that reaching out to people is not nearly as effective as capturing them when they are in clinic. So if it's maybe not quite 6 months and they're well controlled, we might do it a little bit early if they're there. So with that caveat, but definitely no more frequent than the every 3 months.
Okay. What about Med Central?
We do it every 4 months when the patient is controlled. When it's not controlled, every 3 months.
Every 3 months. Okay. What now? This is a question that probably is the answer is going to be that it is the same recommendation. I mean, either 2 times a year or at least quarterly. But if a diabetic patient is in your office and the visit is not for diabetes, but probably is the patient is due for his or her physical, do you also test the patient for A1C even if the patient hasn't or has had a A1C test recently?
This is in diabetic patient? Well, because the physician is going to see him here, it's going to be the same for the whole time he comes. The physician have the EHR completely of the patient, and he needs to have the test done. He will order it. If he doesn't need it, it won't be.
Okay.
Yeah, and that would be the same for us. We definitely always recommend max packing or basically managing all diseases whenever the patient presents. So whether it's a preventive visit, we expect our providers to manage their chronic conditions, or if it's a chronic condition visit and they're due for a physical or a well check, we expect they do the well check as well.
Excellent. Now, for patients with diabetes that is not well controlled, you have the patient has a A1C greater than 9. and you schedule a visit 3 months later, and the result is about the same. Um, what care management approaches do you use to achieve the glycemic targets in these patients?
Well, in MedCentro, we have that patient referred to the diabetic collaborative, and they have an interdisciplinary group there who help that patient to achieve the goal of the AC%. We have a nutritionist, a pharmacist, internal medicine physician. They also get referred to the endocrinologist, nutritionist, and health educator there.
Mm-hmm. Mm-hmm. Do you have different management approaches at Rio, Dr. George? We've been discussing about all the groups that you have, including exercise programs, nutrition programs, and all kind of activities that you do either in the health center or outside. We were talking about an exercise program outside where you specifically when it comes to health to healthy nutrition habits and all and on all kind of different approaches. Is there anything in particular that or different that do you think is an approach that other health centers can put in practice?
Yeah, so one thing that we have started fairly recently is that our behavioral health consultants, they're able to run a report that shows all the patients at their site that have an A1C over 9 who are scheduled on a particular day. And so what they'll do is they plan their day to make sure to see those patients, assuming they show up. And so they'll go into the room either before or after the medical provider, but just proactively, it's expected that they will go see the patients. And so they can help with motivational interviewing and goal setting around their diabetes control. And I think that's really critical because we definitely know that from our data that we have so far that our providers who are already using the BHCs more definitely have much better rates of their patients with A1C over 9. So now we're doing it more proactively for all providers. And then we do, as you mentioned, have a lot of different programs. So it's somewhat up to the individual provider which using shared decision-making with the patient, which approach to take. So we have our clinical pharmacy team who definitely does more intensive management. We can for the patient there. We have our diabetes empowerment program, which we've sort of renamed from our diabetes exercise program, which we also still have a slightly different but similar program. We have our weight management program, as I've mentioned, and then we have a bunch of other like health and fitness type programs. We have dietitians who can see patients individually, although really that's not something I would say the majority of our patients do. We tend to push the groups more because then they also get the group social support, and it's a more efficient way of providing those services. And we, I would say, very rarely refer to endocrinology. Really, the quality of our clinical pharmacists is so high. I think they do a dramatically better job at managing diabetes in our population than the local endocrinologists do. So we really try to, unless people have type 1, I would not refer to endocrinology.
Excellent. Now you're mentioning the referral of an endocrinologist. Is there an endocrinologist at the Rio, or do you refer the patient to another organization if there is the case that you need an endocrinologist in a consultation?
Yeah, we don't have our own endocrinologist, so we would refer out to somebody in the community just based on the patient's insurance.
Great. What about MedCentro, Sylvia? Is there any particular management approach that is being used at this moment for patients who have uncontrolled diabetes?
Yes, in Puerto Rico, because of the law here, the pharmacist can suggest to the patient something, but the only one who can give treatment here or assessment about the treatment is the physician. So we cannot use the pharmacy. The patient has to be referred to the endocrinologist. Here we don't have our own. We refer in the community. They can choose anyone and go there and receive the medical attention from the endocrinologist. Since October, we're gonna have one here. We're gonna contract one, so it's been working with our patient. We also have the wellness program for the diabetes and high blood pressure patients. In the mornings and even in the evening, they have one class. We have a coach that helps them develop their exercise program. From the other thing, we all have almost the same approach for the patient here too.
Excellent, excellent.
Hi, good morning. What I'm gonna be coping is the committee for the empowerment for the patient, so the patient can do it by themselves. We don't have that here.
Good morning. This is Ryan from Tri-City Health Center. I want to chime in with the discussion. So on our agency, what we're doing is we just launched our diabetes wellness bootcamp. So we included case managers, our LVNs, our nutritionists, and our behavioral health provider in this bootcamp. So what we're doing is every Saturday of this month, we identify patients who can benefit from this program. And each classes, we have specific topics for them that we discuss. Like, for example, we had provided the diabetes overview, the pathophysiology, and then we had included some discussions for their diet. And also we had activities for nutrition, like cooking demonstration. And then we had formulated some activities for them that they can use at home, like, for example, simple stretching exercises. So during the boot camp, we are demonstrating these activities to them, and then we are providing incentives, like, for example, stretch bands that they can use at home. And then also we formulated some activities like going to the grocery, wherein we provided information on the specific food that they can shop in that grocery. So in the coming days, in the coming Saturday, what we're targeting is we will be doing a like a walk tour in one of our groceries here, and then we partner with Smart and Final, and then we are providing incentives to them. So in general, we have like 15 cohort in that specific group, and we are monitoring that for a specific like 4 Saturdays. And if this is effective, we are moving forward with the next classes.
Excellent, excellent. Thank you so much for that. It's really interesting. And you know, I'm not sure if you were able to join us in the very beginning, but we were talking about the AC testing A1C testing recommendations. We were talking that the ATA recommendation is to test patients at least twice a year for patients who are meeting the treatment goals, and test the patients at least quarterly if the patients are not meeting the glycemic goals. Is that the approach that you have at Tri-City?
Right now, Jose, we are doing the HbA1c testing.
That's right.
And I'm not pretty sure with our specific protocol.
Mm-hmm.
And right now, we invited our chronic care team to be on the call, and maybe in the coming days for the next call, they will be included and they will be providing more accurate information on our
Excellent,
protocol.
excellent. Now, and then let me ask you this question. One of the primary techniques to achieve glycemic targets is the use of basically the self-monitoring of blood glucose. Do patients have access to glucometers at Tri-City so they can monitor their own blood glucose?
So I believe they have access to the glucometer. However, right now, since we are revamping our workshop for the wellness, and if patients will be coming over, they would have access to the glucometers.
Okay, okay, excellent. Thank you. Now, despite all the efforts, despite all the approaches, there are patients who are still having issues to manage diabetes, and some of them have different barriers. And I would like to talk a little bit about these barriers, specifically in regards to treatment non-adherence in some patients. Literature, I have done some literature review, and the literature basically talks about psychosocial issues, environmental issues, interpersonal issues, socioeconomic issues, and treatment-related issues. What is your experience with your patient in regards to treatment non-adherence? Joy?
Over the past year, I've been really monitoring my patients closely now that we have this relevant program, and I can look not just at my patients coming into clinic, but my whole population. And I think there's a number of different factors. I mean, there's definitely those patients with psychosocial barriers, for sure, is a huge part of it. I do think that once people are on insulin, their likelihood of adherence goes way down, and really having to do with the complexity and just the lifestyle burden of being on insulin. So everything from you having to have it accessible and it being refrigerated, to the complication of drying it up, to having to time it specifically with meals when they might have erratic eating situations. Like I have a number of people who work night shift, and so it becomes very complicated for them to deal with their constantly shifting schedules. So I think one of my thoughts is the more we can prevent people from needing insulin in the first place, I think that's a little bit too late for some people at this point, but that is one of the strategies that I'm developing more, is just trying to really maximize other options rather than going to insulin, other than maybe in the acute phase, having to get them down initially if they come in, the 500s or whatever, but hopefully be able to transition off to something that's more lifestyle reality that people can really stick with. And then just the education piece, I do think that there's a huge barrier of just not knowledge, but I would say more like learning capacity in some of my patients, where no matter how many times both myself and multiple other team members have talked to them about how they're supposed to take their insulin, like that their long acting is at bedtime, their short acting is before meals, and how to adjust it, and things that inevitably they'll come back and they'll be taking too much of their short acting and then thinking they're having hypoglycemia, so not taking their long acting. And we've been through this whole thing with them multiple times, but I think it's really a lack of capacity for understanding some of the complex regimens that we try to put on people. Mm-hmm. So again, getting back to that simplicity being really key, and figure out how to leverage community resources. So for some of those people, they need complex regimens. I mean, that's the bottom line. So it might be somebody who's demented and living with a spouse who's not able to manage that. So how do we leverage, whether it's home health or some sort of chronic program, somebody who could come in daily and give the meds. I mean, I think we need to develop more of these community resources that really, there's a lot of short-term resources, and then there's all text for people who are, which is long-term care for people who are really, severely bad off. But for the people in the middle or people who can't access those programs, we really need more robust caregiving services, I think.
Excellent.
So,
Excellent comment. Thank you, Joy. What about MedCentro in Puerto Rico, Sylvia? What are the barriers specifically for patients on non-adherence, treatment non-adherence?
All of the above that already been mentioned, we have it here too. We have a problem here with the cultural because the eating habits in Puerto Rico are not healthy. And the 80% of my patients are under the poverty level, so they cannot buy healthy food as they want to or wish, because the healthy food here is expensive, more expensive than the unhealthy. So I think this is one of the big barriers here, and people doesn't see or understand the importance of the use of their medication. It's also they're elderly people. They're getting older, and we're having a problem here in Puerto Rico that older people are getting abandoned. So maybe they don't see very well. They cannot put the insulin themselves, and it's very hard now. The younger people are leaving the island and leaving they all here alone.
Interesting. Now, and you are mentioning basically environmental factors and socioeconomic factors. And you mentioned something interesting, specifically specifically the elderly and health literacy. So I assume that health literacy, regardless of the level of education of the patient, is hard, specifically in Puerto Rico. Is that the case? Do patients have issues understanding either the prescription or the number of times that they have to take the medication, or whether the patients have to, if the medication is before or after meals, is that an issue? And how do you try to solve that issue?
It's an issue. We even adapt our EHR, so all of the instruction came in Spanish, because at first our EHR is completely in English. And in Puerto Rico, well, people speak Spanish regularly, so they don't understand English very well, the older, because the younger generation, but they're already bilingual. But we try to translate it. We have a person here who do like comics for them, how to explain it, how to do it, and show them that they're physically. But sometimes, really, they don't understand.
Mm-hmm. Mm-hmm. And what about at Tri-City? What are the main barriers for treatment adherence? What have you seen, and how you are addressing those issues?
So since we have a dedicated wellness department, and that composed of case manager, which is an RN, an LVN, and care coordinators, what we're doing is we are generating reports from our I2I system, and then we identified who are the patients that need focus on diabetes management. So what they're doing is they are calling out patients for uncontrolled diabetes, A1C specifically, and then once they reach the patient, they will be doing counseling and education, and then they are providing information of our services. Right now we have diabetic clinic, and then we identified providers who can manage our diabetes clinics. And then also what we're doing is we are inviting them to our boot camp. We are providing them information on what benefits that they can get from that activity. And also another barrier that we identified is transportation. Mm-hmm. So for transportation, we provided information that we can, there will be a drop-off point if they can't go to our clinic, and then we can transport them. And then another barrier is the language barrier, wherein we had planned to have like for example, Spanish-speaking patients. So for those patients who can't understand English, we have like specific groups who can manage to control their diabetes by providing information with their preferred language. So right now we are revamping, as what I said, our wellness bootcamp, and we are incorporating some activities for them to include and to manage their diabetes with their own selected language.
Excellent, excellent. And you mentioned something interesting that I have as part of the conversation, and the use of electronic health records to um, to try to improve the A1C goals, and at the same time address the barriers. And thank you for bringing that up. That's probably that's a question that I would like to ask Joy too. And how are you using your electronic health record to track your patients and identify barriers to manage diabetes in patients with uncontrolled diabetes?
So we do use eye-to-eye in some capacity. Our RN care coordinator team is using that system mainly around patients who are also being discharged from the hospital or having ER visits. And then they run also eye-to-eye reports and show which one of those are the same people that also have uncontrolled diabetes to kind of take a multi-pronged approach. More, I would say we're using this program called Relevant, which looks at our population level data. And we have had various outreach programs looking by sending postcards for different programs that people would qualify based on either their diabetes control status or their weight. So we've had some kind of targeted approaches in that way of larger populations.
Now, when you use your electronic health record and you are looking for a patient, or you have identified a patient with uncontrolled diabetes, and the patient hasn't other comorbidities, and the patient is at risk of developing some complications, let's say either kidney disease or any eye issue, eye problem, or even the patient is at greater risk of having a heart attack or any other of the diabetic complications. Do you prioritize a patient based on other comorbidities?
Not really. That is up to the provider more.
Okay. Mm-hmm.
We are screening for social determinants of health using the Prepare tool,
Yep.
Which is a national tool, and having the community health advisors see those patients. So we're working on kind of a more protocol-driven based system for that, but people are being screened and connected already. So in that way, but as far as medical comorbidities, we don't really have a formal way of prioritizing that group.
All right. And what about MedCentro Puerto Rico, Sylvia? How do you use your electronic health records to identify your patients and either increase the number of visits or identify any other issues concerning this population?
I have several diseases that our IT have to report me monthly. So every patient that have diabetes, I receive a report of monthly of how their glycemic level are. Those that are over 9, they refer to patient center medical home. It's a department here, and they contact the patient so they can come to visit their physician, and they take care of them.
Okay. Excellent. Now, and I would like to now move on a little bit and talk about, we're talking about barriers to successful manage patient with diabetes, and I would like to talk just a little bit about clinical limitations. What are the limitations from a clinical perspective to successfully manage a patient with diabetes? And just let me give you some examples. Yesterday we had I was part of the conference call with the American Diabetes Association, and some physicians were talking about sometimes there are some issues regarding insulin initiation or intensification of therapy in general, not only insulin but any of the oral drugs that we have right now. So they were talking that sometimes patients are receive the medication, but there is no follow-up, or the medication is not there is no titration. Is that an issue at the health center level, Joy?
I would say a huge issue that has become worse recently is needing prior auths for almost everything. And even with insurances where the medication is covered, requiring some kind of obscure prior auth system, like it might be that we, write for one brand of a particular class of medications, and instead of telling us like, oh, that's not covered, but this other one is, they just don't fill it, and then we find out, months later, the patient comes back and says, oh, I could never get that, and then we find out like, oh, well, this other brand of, essentially the same exact thing is covered, and so, but you have to do a prior auth, and so then there's, jumping through all these hoops. So that definitely creates a lot of delays in getting things started. And then I do think people getting lost to follow-up is less of a problem, given that we have some of these tools to connect with people now that we didn't have in the past. But it still is an issue that people don't come back. You start them on something, and even though they have access to come back, they don't for whatever reason. Yeah, and I think there's great potential in using either texting or telehealth visits to manage, because a lot of these visits wouldn't need to be in person. You could really do titration pretty easily over the phone, or even texting or televisit. So we need to, but of course there's no payment for those services, so we really need to develop a payment system.
Excellent. Yeah, that's something that we've been discussing, and I understand that sometimes telemedicine is an option, but there is the problem that sometimes there is a reimbursement issue for some of the health centers and some of the activity and some of the services that they provide through telemedicine. You're totally right. And what about Tri-City? Have you seen any clinical limitations regarding barriers to manage diabetic patients? And let me give you an example. One of the issues I believe is the variety of drugs that we have, and the adverse effects, and some of these limit the use of the medications, or there are some new medications in the market, and how do physicians receive continuing education on diabetes? I believe that's the question that I would like to ask you. If that is a limitation, the need of continuing education among your clinicians.
Hi, this is Shanita with Tri-State. If I understand your question, because it seemed like it was multi-layered, but the latter part of it is that we are starting to see an increase in the number of participants in our diabetes classes. So, we're looking at, different components for educating the diabetic patients. And as far as adherence to medication, we don't have a strong kind of protocol on that. I mean, when they do come in for the appointments, of course, the providers are following up and making sure that the medication prescribed is working for them and making any necessary adjustments. But we don't have a very strong medication kind of management program for that population, but that is something we will or are looking at currently. But again, we're starting to see the increase in the number of participants in our diabetes boot camps and our classes that we do on the weekends, and we're hoping that starting to see some momentum with those activities, that our numbers will also start to improve. So we're also monitoring under our quality measures that we track monthly. We are monitoring closely the diabetes patients and looking for that improvement in their, just with some of the modifications in behavior.
Okay, excellent. Thank you so much. That's wonderful. Now, part of the operational site visits we've been talking with HRSA is that now, as part of the reviews that health centers are going to get, you are going to have people reviewing the diabetic metrics and your quality improvement program, specifically regarding diabetes. And we're talking about clinical limitations. Do you think that the Tri-City has the staff and the resources to provide all the services that patient with diabetes need?
Absolutely, we do. As a matter of fact, we just had a call yesterday because our operational site visit is in 3 weeks. So we've been just like, our heads to the ground, working late, coming in early, putting in the extra hours, really preparing. And yesterday we were on a call with she's an RN who will be doing our quality component. And we've also been working with our project officer to talk about the activity that they're going to do. And you're right, they are focusing on, this particular measure. And so we kind of wanted to get a little bit more guidance or information from our reviewer for the site visit as to specifically, some things that she was going to be looking at. And so what we determined during the call and after the call, that we definitely have I would say a full team between our, clinicians, our providers, our medical assistants, our wellness team, our data people who put the data together, our people who measure from the quality team, who track and monitor the clinical measures, that from basically A to Z, I think we pretty much have every aspect and area covered. Now, what we're going to start doing now that we've had our call yesterday, we're going to take a look at our PDSAs and some activities that we've done around, this particular measure and, be able to highlight those. But again, my understanding this time around is that they're going to sit down with us and we have to actually do an action plan around this measure when they come out. And that is what she explained yesterday on the call. So I think we identified roughly, if I remember the list, 7 to 8 staff or the team that will be part of this.
Yep, and that's great. Thank you so much for that information. And you were totally right. We had a conference call. The NCAs had a conference call probably 2 days ago, and we, as part of the conversation, we had somebody who is part of who is a reviewer and who is performing the operational site visits, and she was mentioning exactly the same that you have just mentioned. So that's exactly what they are going to do, and in fact, with the findings, if I'm not mistaken, will be used to try to come up with some best practices that health centers will be can use in the future. So that's exactly what the HRSA has in mind. Thank you. That's wonderful. What about Med Centro Puerto Rico, Silkia? Any clinical limitations?
No, because most of the insulin and medication here are covered by the insurance, because like 88% of the patients are in Medicaid. So annually, when we renew the contract, they give us the list of the medication that they're covered, and our physicians are limited to that. They receive all the information annually, and they base the treatment in what is covered by the insurance.
And in regards to training, Silke, and specifically, I'm interested in continuing education. Where do med-central physicians get training, specifically continuing education on diabetes training?
Well, we only have one physician here who is certified in diabetes training, but all of the physicians here in Puerto Rico, we have to have 60 credit in continuing education every 3 years. It's our own. The institution doesn't give us the training. We have to do it by ourselves.
Okay. So you have to find basically the resources to, and get trained. Okay.
Yeah.
All right. And finally, we just have a couple of minutes. This is a very quick question just to finalize our call today. And if you have, you're going to have an operational site visits, and if one of the reviewer asks you what resources have been helpful in improving the A1C target in your patients, what would your recommendation be, Dr. Mogby?
You're saying if we could only have one resource?
I mean, one or more resources. You know, specifically what is working and what is not working.
Right. So I think definitely access to medications is one. Having availability of the behavioral health consultants and our wellness programming would be another. Making sure we have funding for those things. Also making sure we have funding for the population health tools. And then ideally going forward, like I mentioned, some funding for phone visits and e-visits, other more non-traditional type visits.
Yeah, those are great ideas. Thank you for sharing that. Silke, in Puerto Rico, what is working? What resources have you found helpful in improving the A1C target in the diabetic population in Puerto Rico?
One thing, since we started with the EHR, it's easier for me in quality to see how our patients are being taken care of, how their glycemic levels are, and all that are in 9 or more, I give it a text message to the physician, so you have to check for the patient. And another thing is we have a patient portal. So the patient they check their own results. They can do the lab here, and in 3 days they're up in the system and they can check it out. That's something that they've been using a lot. The patient portal. They see the complete EHR. That's what I think this is been improving. And since we started the diabetes collaborative last year, patients are having more adherence to the treatment.
Excellent. And Tri-City, what is working for you? What resources you have found helpful in improving the A1C target goals of your diabetic patients?
Since we have our wellness department, I believe it's our advantage for controlling our diabetes population, since we have a diabetes case manager, we have LVNs and care coordinators, and what they're doing is they are strictly monitoring the progress of our uncontrolled diabetes patients. So I think that's one of the resources that would stand out for the program that we have for diabetes.
Great. Well, thank you so much. It's 2:03. I believe that we are over the hour. So I want to thank Dr. Mogby, Silke in Puerto Rico, and our new friends in California, Tri-City Health Center, for being part of this call. I got excellent feedback, and I am planning to do all the write-up for this conference call and share it with the health centers and all the all those health centers that have been collaborating with us. We are working on the next activities on diabetes, basically for this program year, which ends in the month of July. We have finalized the 4 calls that HRSA asked us to have in the 2018-2019 program year. I'm sorry, 2017-2018 program year. So by July 1st, we are going to have new activities. I will keep you posted on that. I want to thank you for your support, for your feedback, and in regards to training, we are going to have our conference, and we are going to have, in fact, a American Diabetes Association training. Diabetes is primary. This is for clinical staff, including nurses, registered nurses, physicians. So I'll keep you posted as soon as I get additional information. And if I'm not mistaken, this is a half-day training. So I'll send that information out when I have more information. So once again, thank you so much for your help, for your feedback, and have a great afternoon, or have a great morning in California.
Thank you.
Thank you.
Great, thank you.
Bye.
Bye.
Bye.